I'm Michael Fine, President and Board Chair of Primary Care for All Americans. On behalf of Primary Care for All Americans, I'm pleased to welcome you to tonight's Teach and Learn in Zoom. Thanks for joining us this evening with well over 1,600 people from well over 40 states, the District of Columbia, and more than 350 zip codes, with new local state work groups from new local and state work groups from Block Island to California. We're building real momentum as we create a movement that makes primary care for people, not for profit, and starts by providing primary care to everyone in every American neighborhood and community. Thank you all for being with us tonight and for the work you do every day, taking care of patients and building this movement as we take care of more and more of this nation. Now it's my great pleasure to introduce our moderator for this evening, Jason Herde, and to extend my sincere thanks to all the presenters for tonight's events. I'd like to especially thank our Zoom committee, as well as John Wright, Patty Armstrong, and Liv Faraday for organizing this event. Take it away, Jason.
Hi, everyone. My name is Jason Herde, and I'm a third-year medical student at the Ross University School of Medicine. I want to start by thanking all of you for being here tonight. By joining us, you're helping to build a movement, one that focuses on providing healthcare to people in every neighborhood and community. Please be sure to add your name and location in the chat. And as a quick reminder, we don't use professional titles here. This space is about working together and valuing the ideas and the commitments that will drive this movement forward. Now, it is with my great pleasure that I introduce our keynote speaker, Dr. Joseph Gravel. Joseph Gravel is a professor and chair at the Medical College of Wisconsin in Milwaukee. During his 6+ years there, his department has created 3 new family medicine residency programs in urban underserved communities. Dr. Gravel was a program director for over 20 years, was the founding program director of the Tufts University Family Medicine Residency in Malden, Massachusetts, and a program director at the Lawrence Family Medical Residency, a FQHC-sponsored teaching health center in Lawrence, Massachusetts. He is a past president of the Society of Teachers of Family Medicine, the Association of Family Medicine Residency Directors, the Family Medicine Education Consortium, and the Massachusetts Academy of Family Physicians. He also served on the American Board of Family Medicine Board of Directors, the ACGME Review Committee for Family Medicine, and as chair of the Academic Family Medicine Advocacy Committee. Without further ado, take it away, Joe.
Thanks, Jason. Good evening, everyone. It's great to see everybody. So I'm going to share a little bit of what we're doing in Milwaukee. One of the things I want to definitely express up front, we haven't figured everything out. I'm going to share what I think is some successful things, but I want to assure you that it's still a struggle every day in what we're doing, and so it's great to be with like-minded people in the battle for our country's better health and our community's better health. So I'm going to go ahead. I think, can you see the slide? Sure.
Yeah.
No, we can't see them.
Oh, okay. Let me see if I can. Looks like I lose you if I.
John, can you help?
Can share.
Is it what's
I'm
up?
gonna hit share.
You lose seeing the rest of us when you share? Or you're unable to share?
I'm looking, sorry. Oh, that's weird. That just went away. Let me
unspotlight you and just.
Okay, let me, yeah.
Here we go.
Go.
Joe, is that a picture of your
How
boat?
about now? Can people see a lot of flowers?
Yep.
Yep, we got it now.
We got you.
Good. All right. Well, I'm glad we got over that. So anyway, I'm going to talk a little bit tonight about how communities can put medical education to work to increase access to primary care. So a few things that we've been doing in Milwaukee. I think education has been sometimes our Trojan horse into getting more access for people in Milwaukee and Wisconsin. And so if you think of education as a way to get other things done, I think you're tracking of what kind of our experience. A little bit of I came from New England, and I had really not much idea where Milwaukee was. I knew it was somewhere in the middle of the country, but we border Lake Michigan. Medical College of Wisconsin actually has 3 campuses. By far the largest one is in Milwaukee. That was the first campus. It originally was Marquette Medical School, actually, that became Medical College of Wisconsin back in around 1970 or so. And then in the last 10 years, MCW has decided to create medical schools for rural Wisconsin. So Wisconsin's a big state. It pretty much is as large, if not even a little larger, than New England. So I'm in the southeast corner. I'm in the kind of the Rhode Island section of Wisconsin, if you think of it geographically. But central Wisconsin, up in Wausau, Wisconsin, is a good 3.5, 4 hours away from Milwaukee. Our Green Bay campus is about 2 hours north of Milwaukee, and those two were established with the intent to provide access for rural Wisconsinites. Like many states, healthcare was really concentrated only in Madison, which is in kind of lower central part of the state, and Milwaukee in the southeast part of the state. And our department has 5 residency programs. We have 2 in the city of Milwaukee on the north side, and on the south side of Milwaukee, 2 very distinct communities in one city, but very distinct. The north side of Milwaukee is predominantly African-American patient population, and the south side is predominantly, I'd say, Latino, but many different ethnicities on the south side of Milwaukee. Menomonee Falls is a suburban program that started, was one of the first programs in MCW, Greater Milwaukee proper, but only started in 2017, so still relatively young. Our program in Appleton is called the Fox Valley Family Medicine Residency. That's been around for 42 years. So it's one of the older programs in the country, actually, in family medicine. And then our Green Bay program, we started in 2021. They're graduating, I think, the 3rd or 4th class next week. So we pretty much cover the eastern part of the state in terms of our residency programs. The western part of the state is, if you look at it, Minnesota is right next door. So the Mayo Clinic kind of dominates the western part of Wisconsin in terms of healthcare delivery. The northern part is really an underserved area, and I'll talk a little bit about that in a bit as well. So we've got pretty good coverage for the state of Wisconsin. And if you look at the central part, the reason why we're not there is because that's where Madison is, and that's where University of Wisconsin predominates, let's say. So I'm going to focus a little bit on the north side and the south side, and talk a little bit about access, inclusion, opportunities, and our community strategy and education. So one of the things I really want to convey is students are really important to the idea of getting physicians into the community and communities informing what they really want. So we have a lot of different types of programs for medical students at Medical College of Wisconsin. One's the health equity track. So there's some major tracks that a student can select. If they want to be a surgeon, they might choose procedural medicine. But many of the people that go into family medicine and primary care choose the health equity track. There's also an organization called Street Life Communities. That's a very grassroots 501c3 organization that one of our faculty actually started, working on housing and on food insecurity. And then I always feel very mixed when I talk about a Saturday clinic for the uninsured in terms of that we have to actually have such a thing as a clinic for the uninsured. That meets on Saturday mornings. That's run, totally student run. We have family medicine faculty from my department volunteering. I volunteer there periodically on Saturday mornings, and so you definitely see that there are still many people in Wisconsin that are uninsured and don't have access to health care. A little bit about life expectancy and health disparities. One of the things about Wisconsin and Milwaukee in particular is it's got some of the worst health inequities in the United States. It depends on what you look at, but we're usually in the top 5 or the bottom 5, however you look at it, in terms of discrepancies, in terms of many different parameters. One's life expectancy. So unfortunately, this is common in a lot of different places, but if you just look at zip codes, Lake Michigan is to the right, so those are very affluent communities that are right on the lake. You only have to go west about 5 miles, and you're hitting some of the lowest socioeconomic communities that are really struggling because of redlining and a lot of historical inequities. And there's over a 10-year gap with adjacent zip codes. So again, not an unusual situation in the U.S. And certainly we have some of the worst health disparities, and that was one of the drivers to our looking at education as maybe a way to start to approach that and to address that. Infant mortality in Milwaukee, if you're a Black infant, 3 times more likely to die before age 1 than a white infant. And then if you look at homicide disparities, if you're Black in Milwaukee, 20 to 25 times more likely to die by homicide than white residents. So oftentimes you hear, well, the differences in life expectancy is probably just the incidence of violence. And that's not the case. When you look at things like chronic disease, there's some major discrepancies as well. So this is a graph looking at death rate from heart disease. So the white population compared to the Black or African American population compared to Asian, compared to 2 or more races. So very, very large discrepancies in terms of chronic diseases. And if you look at heart failure, emergency department visits, again, astronomically higher in our African American community than in our white population. So still a tremendous amount of work to do here in Milwaukee. And this is substance use, again, mirrors probably the incidents in other places, but again, major area of interest for our department. We're starting an addiction medicine fellowship actually next month that we're really excited about. So again, we're trying to address this somewhat through training family doctors. Every family medicine resident in our department is required, regardless of their perceived interest in substance use disorder, they're required to learn medication-assisted treatment. We just think that that's primary care, but we also want to offer people additional training in addictions, and so we're starting that fellowship. There's a thing called Health Compass Milwaukee that's working together and is working on 5 different areas. One is on violence, one's on mental health, substance use, chronic diseases, and maternal health. Again, very large discrepancies in Milwaukee. So the institutions are trying to work together on these areas. One thing that a lot of people, and I try to educate people in my own institution about this, is primary care access is actually helps reduce violence by acting as a protective factor. So a lot of people don't recognize that primary care can actually be one mitigating factor for violence, which is, again, a major issue in Milwaukee. It enables early intervention for behavioral issues, addresses social drivers of health, provides trauma-informed care. It offers screening for risk factors like intimate partner violence, connects patients with community resources, and offers behavioral interventions. And frequently, we're the front door, certainly, to a lot of behavioral health issues that, if they're not dealt with, manifest in violence. So that's a factor that we really try to impress upon people here. Excuse me. Our department serves the urban center. We've had tremendous growth in patient visits. I won't go through numbers on this, other than saying we're now, through our education programs, providing access to care. Still too many people in Milwaukee have learned that the way to get to any services is through the emergency department. So we're working on changing that culture in Milwaukee because historically the access to underserved communities has been so poor. So that's a process, but we're making a lot of headway into that in a lot of different ways. Where we have a lot of activities. Froedtert is the academic health center that we work with. So we are trying to work with our health partner, our health system partner. I will say it's still a process of explaining to them the importance of primary care in that there's still a way overemphasis on subspecialty care and tertiary and quaternary medicine. But we are trying to find allies within the health system and trying to get more resources for primary care. We work closely with excuse me, a community health center called Outreach Community Health Center. That's where our Northside program is located. So I have weekly meetings with the CEO of that community health center. There's a community services block grant funding project with a 501c3 called UMOS, referring patients to get patients understanding that they can get a usual source of care. We have a mobile health unit pilot project with a mobile health unit van that goes around the city of Milwaukee with our residents on it. We have a lot of individual meetings with our Wisconsin state legislators in Madison. So we've been very successful in acquiring commitments from both sides of the aisle, access or support of our department, and I'll talk a little bit about that. And then behavioral training and Sally Clinford, I'm sure I've already mentioned, and our medication-assisted treatment and addiction medicine fellowship I've already mentioned. So doing a lot, particularly this is predominantly north side and the south side of Milwaukee, more than the other three locations. This is pictures of our north side program. That's again in a fairly qualified health center. And then on the south side of Milwaukee, it's a hospital-based or it's a hospital-owned clinic, but it's standalone. It was a CVS that closed down, and we kind of took that opportunity. It was in the heart of south side of Milwaukee to start a new health center, and that the volumes in that health center are growing in leaps and bounds. So less access via the ER and more access via a relationship-based healthcare delivery. Just to give you a little bit of sense of the zip codes and where we put the two programs, the medical school is right here in the 53226. It's kind of the western part of the city. But if you look at where our north side program is and our south side, the dark blue are the lower socioeconomic status communities. Again, there's a lot of poverty in those areas, a lot of food deserts, a lot of all the issues that you know about in terms of areas and communities that are struggling for support. So we targeted in terms of putting an educational intervention in both the north and south side in those zip codes. Just a brief mention about understanding that a primary care clinic employs the community. So we have a very diverse group of medical assistants, people at the front desk. These are new jobs that were created in the south side of Milwaukee, and it does reflect the community very well. We have about over 4,000 unique patients in over just about 2 years. 14% are Latino, but 66% are non-white patients. So again, we're reaching to people that have not in the past had it. And the reason why we were able to get Froedtert, our academic health center, to pony up and build the center itself was $5 million, was through the education lens. So I think if it was without the education mission, it would have been more difficult to get them to invest. If you look at them historically, excuse me, they have kind of circled the city of Milwaukee, but not been in inner city Milwaukee. So the idea of putting residents in there has really been the way to get that done. This is the class coming in next month, actually later this month. So you can see that we are preferencing physicians. We want physicians that reflect the community and look like the community that they're going to be serving. We also run a refugee program that's been hurt by some of the administrative administration's changes in policy, as you know, but we still have over 250 patients, refugees from many, many different countries, many different languages that our program supports. And again, that's through an education program that we have a faculty member and we have residents and students who work in that program providing those services. We also have we call the CARE program, which is addictions and behavioral health and primary care all under one roof and wrapped in an integrated way. The Southside program, because it's a residency program, we have doctors who can go out and work in these community events, work directly with community organizations, and so it gives us some manpower and some women power to go out there and do that. It's a little bit harder when you have physicians who are kind of their nose to the grindstone. So education really does help with integration of this. We are working with a lot of community partnerships on the south side of Milwaukee. So this is just the logos of many of the different ones, and that's growing every week. This is our north side program. We started with a 14 resident per year program. It's a large program, and I'm just gonna show you, with the photo. Just our one of our goals is, again, producing doctors for an African American community, and we've been pretty successful in that. It's not easy on a lot of different levels, but we've been very intentional in that in terms of our recruitment. This is the class coming in. Again, reflects the diversity of our residency program. We have a very large community engagement footprint on the north side. So community medicine is part of their curriculum, and that we make sure that they are all in the community. They are all doing community events. We have a mobile health unit. Again, we have residents and students on there. So this is actually what inspires a lot of our students at MCW to go into primary care and family medicine, specifically, is experiences like this in the community. They're not necessarily inspired by the diabetes lecture in the lecture hall. They're inspired by these kind of activities. Our community medicine longitudinal curriculum map is just, again, just kind of depicts how much we have our residents in the community. It's really integrated their education, and it's not putting a residency in a community, it's of the community. And I think we've been pretty successful in that way. One thing that if you ever do get to Milwaukee, I would really encourage you to check out is just something called Thrive On. So Thrive On is a collaboration between the Medical College of Wisconsin, the Greater Milwaukee Foundation, and a lot of community organizations. What they did is they took down a boarded up department store this is Central City, Milwaukee on the north side. And they I think it was about $100 million investment. It's absolutely gorgeous space, beautiful space. We have MCW researchers and MCW trainees, both students and residents, in the space. There's a lot of research going on, given this is an African American community, on sickle cell research as an example. So we have a child daycare center in this building. So it's really been a great academic partnership with the community. And so we think it's going to be a model nationally for community investment. And again, it came through the educational focus. We do invite our legislators to come and visit. So this is Representative Rodriguez at Outreach Community Health Center on the north side back in March. So we do a lot of work on legislative advocacy. We are getting $6.1 million every single year from the state of Wisconsin to my department. So when you look at investment in most state governments, it's not of that order of magnitude, but it actually makes us financially viable as a department. We don't have to worry quite as much about clinical revenues. We still have to worry about that, but that definitely allows us to do some really great things, both on the research and education side, because we we do have the support from the state legislature. And as you may know, Wisconsin is a very 50-50 state. I'm not sure you would say it's purple because it's pretty much a sea of red with two huge blue dots called Madison and Milwaukee. But in terms of the legislature, it's very 50-50. So this is very bipartisan it's a nonpartisan issue to produce family doctors and primary care workforce for the state of Wisconsin. So, that's been very gratifying to come to a state where everybody gets it and why it's important. And I'll just mention Advancing a Healthier Wisconsin. That's a research fund that Mel College of Wisconsin and the University of Wisconsin in Madison shares, and that's community-based research. So we're not injecting rats with that money. We're looking at why can't we get mammography rates higher in the north side of Milwaukee. It's very community engagement type of research, and we have the resources to actually do that. The last thing, excuse me, let me just get some water. Last thing I'll just say is rural Wisconsin. So we did have a closure of rural hospitals in the western part of the state in the Eau Claire area. We went to the legislature. We said we still need to serve that part of the state, and so we were able to get $500,000 from the state to support rural rotation. So we have residents from urban Milwaukee going to very northern Wisconsin, western Wisconsin. That's actually starting in July. Again, that was a bipartisan support that we were able to get. So that's what I have for slides. Hopefully that was.
So Joe, it's Alan. First, let me thank you for the amazing work you do for the communities that you serve and you've always done. And thank you for being a friend and a mentor to just so many of us on this call who admire you and your years of experience in education, graduate and undergraduate. So, let me ask a question that actually, kind of came from Dr. Fine. We know there's so many underserved communities. You're obviously making a difference. So how do you go about starting one of these residency programs in a community? Like, how do you make it happen? You've done 3 of them already. You've done them in Lawrence and other places. How do you go about making that happen to meet the needs of the community?
Yeah, so I think it's partnerships, Alan. So I frankly, I was successful in getting a facility built for our Southside program. I went back to the hospital and said, okay, now we got to serve the African American community. They've gotten short shrift over the years. I showed them some of the data I just shared about the infant mortality rate, et cetera. So tried to shame them a little bit into it, or at least made sure that they understood that the city that they were serving had some of the worst health disparities in the country. I couldn't get the money for the north side, so I actually went to an FQHC partner and said, how would you like to partner? You have a problem with recruiting family doctors or primary care workforce at all. You've struggled with this for years. I can bring you the doctors, but I need clinical space. So it was a win-win. So they had the space, I had the doctors, and we were able to go back to the hospital and say, I've got a partnership, I've got space now. All I need from you is some hospital-based rotations, and I do need some support through Medicare funding for their hospital work. But on the outpatient side, we're going to be able to do this through the FQHC. So I think it's partnerships. I think it's working with the community organizations and making sure that the hospital knows that we have the community behind us and what we're trying to do. So you can't.
Question came up from the audience. There's no Joe in the community. There's no Joe Gravel with all your years of experience. So how can a community do this on their own? Like, we know there's so many communities in need, is the first question. The other one is, second part of the question is, do you do things to kind of retain your grads to want to stay in the community that you serve and practice there?
Yeah, so the 2 programs are just graduating their first classes in 2 weeks or 3 weeks. So our retention, so to speak, has been very good. On the order of for Wisconsin, about 70% stay in the state of Wisconsin. About 65 to 70% are staying in the greater Milwaukee area. That's a common thing is, they say 70% of graduates stay within 100 miles of where they train in residency. A lot of times people look at where they trained in medical school, but where they train in residency is actually much more important. So there's a robust desire amongst small businesses in Wisconsin. A lot of the industries, dairy industry, all these other, they understand that they cannot attract workers to their community if they don't have doctors. So we really try to partner even across our academic institutions. I work very closely with the chair at University of Wisconsin, and we actually are working right now on trying to get the legislature to increase the primary care investment in the state of Wisconsin. In terms of funding, it does help to. It's very complex in terms of the way Medicare funding works. As you may know, or many of you know, there's absolutely no accountability of a hospital and what they're training. They don't have to, there's no accountability in terms of taking federal tax dollars and producing what the community actually needs. So some of it is, I think, just trying to put a spotlight on things like looking at data of health professional shortage areas, trying to develop in my role in the academic side, trying to leverage my relationship with the dean and with the health system partners. But I do think the north side is probably even the better example of if we didn't have community support of doing this, there wouldn't be a north side residency program. So I would say trying to create academic partnerships with community. I think there's a lot of nuances. I know Wendy Barr's on this call, and she's just trying to start a new residency. So there is some expertise that is required, but I think building bridges to the community, looking at what the common needs are of the community, then you can leverage that with trying to get the hospitals to do the right thing. Hospitals also have boards of directors, so understanding who's on the board of director of your hospital, and however you can get it done in your particular area. But certainly, primary care models, I think, certainly in terms of the training environment, the community is by far the best place to do it, not in a tertiary academic health center. Our residents learn inpatient medicine in a tertiary medical center, but they're spending the vast majority of their training time in the community, in community engagement type of activities, as well as in the clinic in the community. These are small, relatively small sites that they're spending most of their time seeing patients in.
Joe, fabulous. And again, thank you. And before I hand it over to Dr. Fine, Michael Fine, who needs to say a few words, I'm in trouble now. I have a great idea, Michael. I'm going to twist Joe's arm to help us form the playbook for starting residency programs in communities of need. So we're going to start harassing him for that. So, Michael.
Before I take that handoff, you might want to open it up to the audience for a couple of more questions. I think we have time for a couple.
Okay, I don't see anything in the chat. Anybody have any questions? I see a hand. No, I see applause.
Anybody have, Joe, while we're waiting, I'm really interested in this notion. Oh, Matt's ready. Matt's trying to do a similar thing in Woonsocket, Rhode Island. So Matt,
Yeah.
why don't you go ahead?
Joe, I don't know if you recall, but you were actually our advisor through
I remember you. Yep.
Yeah. So we are in the process of recruiting our first class for our family medicine residency. It'll hopefully start in July. Unfortunately, the feds pulled the rug out from beneath us with the teaching health center funding. So we're just trying to work with our legislature. And some of the reaction we get is, wow, this is really expensive. And like, why is it so expensive to train physicians? And why are you asking us for it? Because like hospitals are doing it and not asking for state funds. So like, how do you kind of break through that when there's hospitals running residency, obviously built on Medicare dollars, and when you try to do it in FQHC, you don't have access to that?
Yeah, it's good to see you again, Matt. And congratulations on getting that up and running. Um, One thing about the Teaching Health Center program, I'll just mention. Um, so my department started their first Teaching Health Center in Wisconsin, and we closed the first Teaching Health Center in Wisconsin. So the long story, and I won't go into it, but a lot of issues with HRSA, a lot of issues with frankly, the FQHC that we were partnering with. We found another FQHC, and because the train had been already going down the track, that's where I went back to the dean, went to the president of the university, and went to the hospital and said, "You can't pull the plug on this. You've got to step in and pony up here." In terms of the expense, it does look like, boy, it's a lot of it. It's very expensive to train a family physician or a primary care physician, and so my response on that is giving them some data about. Well, it depends what you want. If you want to keep spending more and more and more money on the health system, if you want to, we're lapping the field big time by just having a specialist driven and lack of primary care access, then ultimately you got to look at this as an investment, not as a cost. And there's many, many, many different papers that have been written and studies that have shown that we actually have the data that show this, that outcomes are better and costs actually go down. And so if everybody loves paying the percentage of dollars that they have to, if they're a small business, to for their health insurance, or they love governments having to not pay for parks or schools because they're paying for health coverage. It's one of those things that you just got to make the investment, or you just accept the status quo, and the status quo is not acceptable on many, many different, not only a financial point of view, but a human point of view. That's what I really focus on as much as I can. But it's definitely not easy talking to I still am fighting battles with the tertiary health center about why they should. I would like to expand our South Side residency, for example, and so I keep putting the seed. We should have 8 residents here, not 6. And it's not like I ask and it happens. Sometimes I just wear them down. Sometimes just at least with the 6 per year, I'm showing proof of concept that the retention rate for your health system is really extremely high. You don't have to spend a lot of money on recruitment. You don't spend a lot of money on all the arguments that you already know. Is I think the arguments you make.
Larry Bauer has a question. Mr. Bauer.
So, Joe, well done once again. I'm wondering if you've had any luck with philanthropy. Up in Appleton, there was a young woman there whose name I can't remember, but she came to our fundraising fellowship training program many years ago and talked about what she had done with the Appleton Family Medicine Residency Program. I'm just wondering if there's been any more success with that.
So you're probably referring to Lee Vogel.
Yes.
So Lee Vogel is in my department, and she just retired 2 months ago or so. She's still working point 2. If you ever get to Appleton, Wisconsin, you should see the facility that Lee Vogel built, and that was through philanthropy. A lot of it was philanthropy. She's been much more successful than I have been on philanthropy. I probably spent more time haranguing the hospital but that's an area that we need to do much better. My whole institution needs to do much better at. We don't do a very good job as an institution. My department doesn't do a very good job in terms of that. But Lee has been very successful in Appleton to there's a thing called health. It's the nicest family medicine residency site I've ever seen. It was just spectacular. It just opened in May. So
I think Catherine
I
has
would
a question.
imagine-
If you could come off mute, Catherine.
Go ahead.
No?
Mr. McDaniel? Nope.
All right,
Sorry,
Larry.
what's that?
Did you have a question?
No, I was just celebrating that Massachusetts is perhaps following Wisconsin's lead and having the state legislature actually devote millions of dollars to this.
Okay, Jeff?
Well, super impressive what you've been able to do, and between your energy and enthusiasm and meeting the needs of the state and meeting people where they're at. I'm just curious if you could say more about how you partner with medical and other allied health students to work at the grassroots level in communities, because it's I would say that the mobile unit is great. Maybe the lecture on diabetes is also good, but how do you get them engaged long term in a constructive manner?
So Jeff, you're talking about other health professionals, or pipeline programs?
Starting with medical students, if that's been your effort, but
Yeah,
getting people.
Yeah, the health equity track, the Salary Clinic for the uninsured. I sign up for that and I say I have to go there. It pretty much goes a lot of the whole day salary. And once I get there, it's like my batteries get recharged by the idealism of the students, and they are running the clinic. I'm not. I'm just there to supervise the care that's being delivered. So that's been a life-changing experience for our students. Again, I'm very ambivalent that we have this crazy thing called Salary Clinic for the uninsured in a country like this, and with all the resources we have and all the medical resources we have, but that's been, I think, a game changer for a lot of students. It also gets them rubbing shoulders with family doctors. And so I think they see kind of our ability to maintain our sense of idealism as well, that we're over there volunteering on a Saturday. So I think that's been a real win-win. We actually do require all our residents to go there and volunteer. I volunteer them, whether they feel like they're too tired or not. I just think it's really important that they have that experience, and we have some really wonderful conversations with students about, isn't this a crazy system that we're sitting here on a Saturday and and there's still a lot of challenges to getting them specialty care, getting them their medications, coordinating the care. So it, you could talk about theory and health policy, but boy, when they see the faces of people coming in and people that don't have access to care, that's better than any lecture I could give on health policy and why the system has to change.
Thanks.
Again, Joe, thank you so much. Let me hand it back over to Michael for some comments.
Thank you again, Joe. Thank you, everybody. But Joe, it's incredible work. The real opportunity is for communities to start figuring out how to do this for themselves, use philanthropy, and partner with academic folks. There just aren't enough Joe Gravels to go around. And so we need to be helping communities figure out how to do this for themselves. My rough guess is that any city with a population of 50,000 or more ought to have its own primary care residency, because we are so far behind the eight ball from a workforce perspective. That's to get us to primary care for all Americans. We just heard now 2 weeks ago at our summit about primary care for all Canadians, which the Canadian government has committed to by 2029. That's our friends and neighbors to the north. If they can do it, why can't we? And speaking for myself, we'd be thrilled and honored to follow their lead and get to primary care for all Americans by, say, 2030 or 2032, I'll take any of it. But like I said, if they can do it, so can we. This is doable. All we need to do is to stand up together and do it. So to everybody, please make a call to a friend or a colleague tomorrow at 8 a.m. and start that local work group tomorrow, first thing in the morning. Hey, Texas, and just not for nothing, Wisconsin, California, and New York have primary care for all American state work groups. Time for you guys to jump on board and get first hundreds and then thousands of communities engaged in doing this for themselves. We really can do this together. To the skeptics and the doubters, this is words from another time, but yes, we can. We've been proving it around the country. We can do this. And to quote somebody smarter and wiser than me, if we try, we will succeed at last. Now I'd like to introduce Lindsay Lopez, our social media lead, who'll talk about how you can support primary care for all Americans through our social media channels. Lindsay.
Hi, everyone. I just wanted to share a quick reminder to follow us on social media if you haven't been already. And if you are, thank you so much. Following us really helps us grow our movement and connect with people we might not otherwise reach. And you can actually connect with other people who have the same views, especially on LinkedIn, and you can network. And every like, comment, share, tag, repost, honestly, any interaction helps us reach more folks and learn about what we're doing and why it matters. And we're talking about real wins from all the local work groups, like Michael just said, whether it's Rhode Island, Massachusetts, New York, California, anything happened nationally too, we report on. Primary care stories and developments around the nation. We post clips from teach-ins like this one. So if you missed another teach-in, we'll post little recap clips. And we just share community voices. And these are all the community voices that want to spark change, just like you if you're on this Zoom right now. So if you're passionate about making healthcare better, more fair, more human, follow us, stay connected, and help us spread the word. I'm going to drop the handles right now in the chat. You can also check out some other fun links in that bit.ly link I just sent. Thank you guys so much.
Thank you again for joining us tonight. In 1 month, we'll be meeting again, and we encourage everyone to invite someone new to get involved in our movement. Mark your calendars for July 14th, where we'll be hearing from Dr. Andrew South. You can register at our website, www.primarycareforallamericans.org, where you can also check out our local and state playbook, volunteer, and donate to support our cause. Thank you again to Joe, our facilitators, and thanks to everyone for joining us tonight. I hope you have a great evening. Take care, guys.